No? Maybe the panel have you got any comments on each other's presentation?
Can we go back to the OPG, whether we advocated, I think for the maxilla, it's not good enough just to have a orthopantomograph, because you have no, the size of it. I mean, you don't know what is the width of your maxilla. So I think probably for the maxilla, especially the posterior maxilla, a CT scan's advisable. That's what, I mean, this is a personal view.
Okay, those of you who read Thursday's newspaper, the Mind Your Body section, they talk about this CPG, and the reporter came by and we have a little chat. And see, to a lay person, a lot of times they assume. I mean, when I say that, not we try to write up guidelines as evidence-based, and she was a little bit puzzled. She said, "You mean you all do things that are no evidence, that's not evidence-based?" So I said, well, actually, a lot of things that we do have no evidence-based, and as evident in the presentations today, we are here trying to present the evidence-based guidelines. But along the way, you find that, like what say Victor said, you look at the grade of recommendations, a lot are the C grade, and it's simply because the quality of the publications that's available out there is not that rigorous, and for obvious reasons sometimes, because we're talking about clinical studies. You cannot kind of like group people together and just experiment on them, right? So, and you will never be able to get identical people. It's not like you do animal studies on mice, so you get one batch of mice that is genetically similar, and then you can do certain experiments on them. But humans are maybe a little bit different. So the rigor of the science behind some of these papers will not be as strong, and hence we cannot make certain strong recommendation based on that. So but smoking, the detrimental effects of smoking is rather common sense. So we try to find the evidence to support that, and in the absence of well-conducted scientific studies to prove it, we can only give a lower grade recommendation. But it doesn't mean that the recommendation itself is weak per se. So you've got to look at it in the overall realm of things. If there are evidence, say like in contrast, the other section, the last question in the CPG on immediate loading. Immediate loading has a lot of very good data. So most of the evidence, I mean, there are meta-analysis of randomized controlled trials, and there are quite a few of those. Very well conducted studies and very critical analysis, and we can make very good recommendations on those. And because these are relatively selectable patients, in a sense, they have a certain, the patient group is a little bit more homogeneous. So you take, for example, fully edentulous mandible. Most of the fully edentulous mandibles belong to patients of a certain profile. So it makes it a little bit easier to choose these people. We can exclude confounding factors like patients with any kind of medical condition, and there's still plenty of these patients to go around. And for this kind of measurement of success, there are many parameters that you can measure. You can measure bone loss over time, you can measure probing depth, etc., etc. So when you can have clear parameters to measure in a relatively homogeneous population or populations of the subjects that you are studying, then you are better able to make a higher grade recommendation. So a lot of the statements that even we hear today, or a lot of the large part of the lectures, is not evidence-based. But does that mean that we're not doing the right thing? Maybe, maybe not. But overall, we should lean towards finding more and more evidence to support what we do. It doesn't mean that, I think, was it in yesterday's papers or 2 days ago in the newspaper, they were talking about the court case against an aesthetic physician, the judge ruling that or the physician's justification of her doing non-evidence-based stuff is that a lot of people are doing it anyway, so I can't be wrong, right? So the fact that a lot of people are doing it doesn't make it right. It may not be enough to get the patient into trouble. That means that you may not be enough to get the practitioner into trouble, but it still doesn't make it right. And overall, as a profession, we should move towards working on evidence-based treatment protocols for our patients. And where there aren't, where there's insufficient of such evidence, then perhaps people in our tertiary centers can do some research to help us find the evidence for it. Right. No other comments? All right, with that, thank you very much, and hope you had a good time. Thank you.